Good afternoon, everyone, and welcome to Medical Grand Rounds. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which people of the world now gather. Today, our speakers are courtesy of the Division of Rheumatology, and I'd like to ask the Chief Rheumatology, Dr. Beth Ezel, to please introduce our speakers. Beth?
Yeah, thank you so much. It's my pleasure to introduce these two amazing women. Stephanie Tom is coming to us from Mississauga, where she's a lecturer at University of Toronto. She is passionate about climate change. She was the founder of the Ontario Rheumatology Association Climate Task Force and is now the chair of the Canadian Rheumatology Association Task Force in Planetary Health. And then she's joined by our own Sasha Bernatsky, who's both a rheumatologist and an amazing epidemiologist, James McGill Professor of Medicine at McGill University. She's a member of CORE, the Center for Health Outcomes Research at the Research Institute, and she's a senior scientist affiliated with infectious disease and immunology in our RI program. She co-leads the Canadian Network for Advanced Interdisciplinary Methods for Comparative Effectiveness Research. And her career has really been marked by looking at the effects of air pollution on rheumatic disease. So I will pass the baton to these two great speakers.
Thank you very much. Thank you so much. So it's a pleasure to speak on this topic. In terms of goals, we're going to describe ways that climate change may affect our work as physicians. And in fact, we're going to be giving examples from rheumatology, but I think you'll see that this applies to physicians and healthcare workers, no matter what kind of patients you treat. We're going to look at the evidence that air pollution in the context of climate change may affect rheumatic disease, particularly because it is an area of research interest to me. And then I'm going to hand it over to Stephanie, who's going to explain the role of physicians. So again, she'll give examples from rheumatology perhaps, but it really applies to all physicians and healthcare workers in practicing sustainable healthcare, which is kind of the antidote, we hope, to some of the ills of climate change that we'll be discussing today. So I'd like to bring up a definition of climate change so everybody's kind of on the same page. I'm not a climate change specialist, but here we go. So this is from the United Nations webpage. Climate change refers to long-term shifts in temperatures and weather, which can be natural due to sun's activity or large volcanic eruptions. But since the 1800s, climate change is thought to be primarily due to the burning of fossil fuels. So last year, the WHO sounded grave alarms concerning climate change and emphasizing huge direct health costs, increasing by the year 2030 to 2 to 4 billion annually in US dollars, with hundreds of thousands of early deaths and the potential to undermine decades of progress in global health. How can climate change presumably affect Canadians with rheumatic disease, or really all Canadians? So as I go through this talk, I'm going to be kind of putting things under these 5 categories. So we'll talk a bit about temperature extremes that are related to climate change. That can be extremes in heat, but there's also a lot of fluctuations in temperature that we see with climate change. And I think we may be experiencing that as we see a few days of like super hot weather in June and then really cold, unseasonably cold temperatures. So we'll talk about how those fluctuations as well as the extremes might affect Canadians, particularly those with rheumatic disease. Then we'll talk a little bit about vector-borne diseases and how that can affect us as rheumatologists or generally as physicians, and think about infectious complications that might be changing and particularly affecting immunocompromised individuals. Then we'll move to just a little bit about natural disasters, particularly forest fires and evacuations, and how that might affect mental health. And I'll end, as mentioned, with one of my favorite topics, which is air pollution and rheumatic disease. Questions: can temperature extremes affect Canadians with rheumatic disease? So, you can pose this question as, do extreme ambient temperatures, especially when they're prolonged, affect the immune system? Because we know immune system drives our autoimmune rheumatic diseases. So there's a lot of research yet to be done on this topic, but there's accumulating data in animal studies that yes, ambient temperatures can affect the immune system. We do know in humans that humans are pretty good at maintaining an even core temperature despite changes in ambient temperature. But we also know that that ability is impaired in older individuals, and seniors are the population that is more at risk for different rheumatic diseases. And in fact, we can say that's true for most of our diseases, right? And it turns out that even small changes in core body temperature, like 0.6 degrees Celsius or more, can affect the immune system. We can also ask, can temperature extremes or dramatic fluctuations exacerbate rheumatic disease symptoms specifically? And it turns out there's a lot of information suggesting that temperature, barometric pressure, and humidity, which are all related, may correlate with joint symptoms. So that's been shown in OA and RA. So next, we're just going to talk a little bit about vector-borne diseases in the context of climate change. So I think that everybody's favorite example is Lyme disease, how with climate change and changes in weather patterns, we see the prevalence of the ticks that harbor the pathogen responsible for Lyme disease is increasing in prevalence. So that, of course, has implications for all of us, I think, as physicians, including rheumatologists. But I want to talk for a bit about a few other issues that are important that maybe aren't on our radar screen. So as general principle, climate change can alter the distribution and prevalence of disease vectors like ticks and mosquitoes. And West Nile virus is actually the leading cause of mosquito-borne disease in North America. And changing weather patterns, especially warmer winters, can affect mosquito levels. So with milder winters, more mosquitoes can survive the winters and lead to higher levels of mosquitoes come the spring and summer. This is important for us, particularly those of us who have individuals who are immunocompromised because of the drugs we give or other reasons, because West Nile virus can result in really serious and invasive disease. So you'll see case reports all over the literature about that. And there are other vector-borne pathogens that the same thing is happening. So we think about malaria and dengue as diseases that are happening in other countries like Africa. And it's true that the mosquitoes that transmit these diseases are on the rise in Africa, but it might also be the case in North America, or at least the United States. So you see here some headlines from the past year, including some people in the United States who seem to have acquired malaria in the United States. Moving on now to talk about climate change and forest fires and how that can impact health. We know that climate-driven changes in weather conditions, including higher temperatures and lower precipitation, are associated with more frequent and severe wildfires, as we've been experiencing in Canada and elsewhere. Though wildfires occur in remote areas, the smoke travels far. And so we again saw this last summer where forest fires in the north, the smoke traveled and affected air quality in Montreal and in New York City, as you'll see in this kind of dramatic thumbnail. It's also true that over time, more people are being affected by wildfires, and that's due in part to the greatly extended wildfire seasons. They used to happen in early summer and extend to late fall. Now the time period is even longer. The wildfires are also larger in area and coming closer to highly populated areas, both because of the expansion of the area of wildfire and also because of our population expanding. Unfortunately, we had record-setting wildfires in Canada in 2023, beginning in March of 2023, and about 150 fires from last year managed to smolder underground over the relatively wild winter and reignite in February 2024. So an even earlier wildfire season this year. So of course, with wildfires, we have evacuations. And last year, 250,000 Canadians were displaced due to wildfires. I didn't realize this until the fall when I was speaking to somebody from Northwest Territories, but 70% of Northwest Territories was evacuated last year at one point. 25,000 people from Quebec were evacuated last year, including the entire population of Chibougamau, which many of us have patients from that area. And in 2024 so far, already communities in Alberta and BC are affected or threatened by evacuations, such as Fort Nelson in BC, Fort McMurray in Alberta. So this, of course, leads to disrupted healthcare infrastructure, including physician access and lab monitoring, and presents difficulties with access to and storage of medications. Now, if patients are evacuated in Quebec, they can go to any pharmacy and get a redispensation of their medications, but they may still have problems, for example, storing medications that need to be refrigerated, and then the whole problem of medications that need to be infused is really difficult. Now, unfortunately, climate change has not just physical effects, but also mental health effects. So some of these affect all of us, but maybe people with chronic diseases like rheumatic disease may be particularly at risk. So climate change related events can lead to increased stress and anxiety and depression. And if you think about it, these are actually known to affect the immune system and inflammatory pathways, and they're all predictors of worse outcomes in rheumatic diseases. So it's not that there's specific research showing that climate change related stress leads to worse arthritis, but you can see that's a pathway that's pretty easy to invoke. Another thing to think about is that people with complex rheumatic diseases who are directly affected by evacuation may be particularly vulnerable because of disrupted access to medication and services that may be quite complex, mobility issues, and increased risk of injury or infection when they are evacuated. But stress and anxiety related to climate change events affects most of us. So in a recent survey, 75% of Canadians said they're expecting at least as bad forest fire conditions in the future, or maybe worse. So now I'm going to talk for a few slides on air pollution and rheumatic disease. So so it turns out that air pollution is not simple. So it's not made up of a single entity. Of course, you've got a mixture of gases and particulate matter that's suspended in the air. And there's a lot of focus nowadays on fine particulate matter, which is a kind of particulate matter in air pollution that is quite small, less than 2.5 microns in diameter. And the reason why this is of such interest is it's small enough when it's inhaled is to get all the way down to the alveoli and actually be absorbed into the bloodstream. And there it can elicit a host of different effects within the bloodstream, including triggering inflammation. So I have two kind of graphics here. One is a little cartoon that just emphasizes the little PM 2.5s that pose the greatest harm potentially. And in this the pathways that I've kind of showed here, these are, well, I won't say theoretical. They're all pathways that have some published evidence supporting them, but it indicates that once PM 2.5 is in your bloodstream, there's many pathways that can trigger inflammation and potentially cause autoimmunity and rheumatic diseases. So PM 2.5 is important in the context of climate change because as vehicle and industry-related emissions are under stricter control in the developed world, wildfire smoke is actually starting to predominate PM 2.5 exposures. Of course, besides PM 2.5, wildfires produce all kinds of really bad things to breathe in, like carbon monoxide and other compounds, and contributes to ozone formation, which is helpful if it's in the atmosphere protecting us against UV light, but is not good when you're breathing it in. So just a little bit more about PM 2.5 and another graphic where you see PM 2.5 is very small, much smaller than a human hair or even a speck of pollen. Another thing that I'm not going to have time to talk about, but it turns out that PM 2.5 comes in different sort of flavors, shapes, sizes, and is made up of chemical components that I've listed here. And probably the composition of PM 2.5 does affect how toxic it is and maybe some of its health effects. But it is that inhalation of PM 2.5 into our blood system that could be mediating some of the systemic effects that we think PM 2.5 has. So I have one slide describing some literature regarding PM 2.5 and rheumatic disease and systemic lupus and other systemic autoimmune rheumatic diseases, and then I'll have a slide on rheumatoid arthritis. So ambient PM 2.5 has been associated with the presence of more anti-double-stranded DNA antibodies and cellular casts in lupus patients. We were the first to show that in the McGill University Health Center lupus cohort. PM 2.5 is also associated with lupus and SARS prevalence and incidence, and we showed that using administrative health data in Canada. PM 2.5 has also been associated with lupus admissions and lupus rash and arthritis. And there's actually good basic science behind this because chronic exposure to PM 2.5 aggravates lupus manifestation in lupus-prone mice. Regarding RA, the literature is a little bit more heterogeneous. So RA risk has been linked to very high PM 2.5 levels and PM10, which is another form of particulate matter, in Korea, Taiwan, and Italy. However, there was no clear association between PM 2.5 and rheumatoid arthritis onset in one study from the US, published by Hart in 2013. And I think it's important to realize that over time, the methods used to assign air pollution exposures to individuals has really improved. And this is in part due to the use of satellite imagery, where you can use the satellite images plus sophisticated models to assign exposures of particulate matter and other air pollution exposures at the level of the postal code. So recently, we used administrative health data to show greater risk of RA onset with higher ambient PM 2.5. We also showed links between industrial PM 2.5 and sulfur dioxide with anti-citrullinated protein antibodies in banked sera from the CanPath general population sample. And anti-citrullinated protein antibodies are a really specific marker of rheumatoid arthritis risk and progression. There's also literature showing other associations between PM 2.5 and anti-citrullinated protein antibodies in rheumatoid arthritis and rheumatoid factor and PM 2.5 among first-degree relatives of people with RA. So just to summarize, rheumatic disease patients, and in fact, many or maybe all of the patients that we serve as physicians are vulnerable to heat waves and temperature variability. Changes in patterns of vector-borne pathogens pose risks to patients, especially those taking immunosuppressives or who are immunosuppressed. Over time, more people are being affected by poor air quality related to climate change, especially particularly related to forest fires. And I think we can appreciate that vulnerable populations often live in areas most at risk. So a lot of forest fire activity in our Canadian North, and that's where a lot of First Nations people reside. And certainly First Nations are at higher risk for rheumatoid arthritis and systemic lupus and potentially other conditions. And we touched on the idea that evacuation certainly has both physical and psychological impacts. I just told you a little bit about some of the data linking air pollution, especially PM 2.5, with clinical and serological features of rheumatic disease. And as industry and vehicle emissions are more regulated, PM 2.5 from forest fires is emerging as a significant threat. So that's it for me. I'm just going to mention, though, the CanRAD network, which is a collaboration between the Public Health Agency of Canada and researchers and other stakeholders. We've some of the data on air pollution and rheumatic disease was performed using administrative health data. So that's just an example of the benefits of this network. So now I'm going to pass it over to Stephanie, who, as Beth mentioned, is the chair of the Planetary Health Committee for the Canadian Rheumatology Association.
Hi, thank you. So first of all, I just want to thank Sasha and everyone for the invitation. So I'm a community rheumatologist. I'm working out of Mississauga, Ontario. So I just wanted to preface by I'm basically a full-time clinician and just worried about this topic. So I don't have any major credentials, but I'm really more focused on the knowledge translation piece of this issue as well. So what I'll do is switch gears a little bit from what Dr. Bernatsky has presented and then talk about what we can do as physicians within our own practices and also in our institutions. So I'm speaking to you from Mississauga. So it's originally from the territories of the Anishinaabe, Huron-Wendat, Haudenosaunee, Ojibwe, as well as Chippewa peoples and home of the Métis, and also descendants of the Mississaugas of the Credit. So I have no industry disclosures. I do get honorarium for being part of the Ontario as well as the Canadian Rheumatology Association. And most of it is actually being from a volunteer role in terms of this interest. So to switch gears, what I'm going to do is actually is to describe ways that climate change can affect our work, as well as to explain our role and what we can do from a practical standpoint. So I'm actually going to cover a huge topic because I'm sure everyone has an opinion personally or professionally about the environment and what it means. So I'm actually going to cover what it means globally, what it means in healthcare, and what does it mean to our day-to-day work. So first of all, I just wanted to throw it out there. So I'm going to slightly different style of presentation from Dr. Bernatsky's, but just to ask everyone in the privacy of their own homes or offices or wherever you're hearing from right now is how old are you right now? And how old are you going to be in 6 years from now, which is 2030? And how old are you going to be in 2050? And the reason why I emphasize this is that you can throw out any of the previous environmental messaging, which is think about the grandchildren, think about the future generations. It's really about thinking about our personal and professional legacies because these topics and these consequences are affecting us now. So you may have seen variations of this graphic, and it's really looking at the different projections of what the temperature targets will be. And ultimately, when you hear in the headlines about this 1.5 degrees Celsius, it's really the threshold of what global average temperatures are like compared to pre-industrial levels, which is when the flurry of all our human activity has created to rapid rising temperatures, but has also afforded our modern lifestyle. But 1.5 degrees Celsius is what climate scientists have determined as the threshold that we're beyond the point where the climate has the resilience to adapt to all the changes it's gone through. And we're then in a positive feedback loop of expected to have increasing as well as intensity of natural events, which can, of course, have major personal as well as economic impact on human societies. So when I give variations of this presentation, someone invariably always asks me, what about China? What about the US? So I want to acknowledge a global context, which is, yes, both of those countries are major carbon emitters, but we also have to put into context of how interconnected our world is. A lot of our manufacture, for instance, comes from China. A lot of our food comes from the US. So this is also to acknowledge that there are different countries doing different things, different industry doing different things, but regardless who isn't or isn't doing what, ultimately the consequences are going to affect us as Canadians. So when I did a deep dive on the topic, so again, I know people keep calling me an expert, but I'm going to be honest, I'm a full-time clinician, and I've only did a deep dive on this 2 years ago because that was when I was on maternity leave. So during my maternity leave, I had a bit of bandwidth to learn more about various topics coming out of the post-pandemic chaos of doing medicine as well. But in summary, it was this one fact that I learned that inspired me to even think about doing anything about this topic. And the one fact, if you remember nothing else from my part of the presentation, is the fact that healthcare itself has a carbon footprint. And in fact, our carbon footprint is larger than the aviation industry, just at under 5%, both in Canada and globally. And to recognize that it was our day jobs, which also goes into evenings and weekends, is where we can have an impact, was both shocking, but also inspiring, because I was thinking maybe we can do something about this topic. So just an example, all the medications we order, all the equipment you use, it all gets manufactured somewhere. So for instance, a medication may be manufactured in India, it gets shipped over to California for processing, it goes up to, Ontario for packaging, it gets shipped out to Quebec, and the patient will eventually take it. So all of these things contribute to our emissions within the healthcare sector. So when you now break down healthcare footprint per capita basis, Canada suddenly pops up in the top 4. This is likely due to a relatively small population over a large geographical landmass, and the fact that we provide a lot of different health services as well. So this is from the Lancet Planetary Health from 2021, and they looked at the NHS system to see where these emissions were coming from. And 2/3 of this was actually coming from the supply chain. A quarter of it was related to direct patient care, and about 10% was related to patient and staff travel. So what else is happening in Canada? So keeping in mind this is medicine rounds, I just wanted to give a few, most of the examples are from rheumatology, but I also want to acknowledge the other work done in other areas as well. So for instance, as concrete examples, anesthesia is really working out to phase out desflurane. So that is one of the older anesthetic gases that is being used, but has a higher carbon footprint compared to other equivalents. In respirology, which we'll talk more about, is if when there's a medication equivalent, picking the more eco-friendly option. When it comes to the surgical world, in terms of the ventilation as well as reducing OR waste is an initiative being undertaken, both from the environmental lens, but also from a cost savings perspective as well. Our ID colleagues, as Dr. Bernatsky mentioned, about vector-based borne diseases. And our primary care colleagues are focused on deprescribing and getting rid of exam table paper rolls, more on that later. And our radiology colleagues realize that sometimes up to half of the energy of their devices are being spent when they're in standby mode overnight, when they're not in use. And our emergency colleagues, similar in BC as well as Quebec, sometimes they're starting to realize maybe they should brace for wildfire season each year the way they brace for cold and flu season, unfortunately. So this is an example of what other organizations are doing as well. So for instance, the Canadian Thoracic Society has a position statement and is really about specifically meter dose inhalers. So just as a quick tangent, the big environmental campaign of the 80s was really about saving the ozone layer. But what I realized in my learning journey is that a lot of environmental regulations exempts healthcare and healthcare devices, because there's often concern about the downstream effects and potential patient safety, which is why our role as clinicians or as researchers or educators really lends a unique lens to this issue. So for instance, they talk about, from the evidence-based approach, first of all, confirm the diagnosis. So most of the data is really about asthma as well as COPD management. So confirming the diagnosis, appropriate use of the medication first. And then from then on, through a patient conversation, if it is appropriate, let's say, for example, a stable asthmatic patient or a patient with asthma, is if it's appropriate to actually switch them from a meter dose inhaler, because the little propellant that we have is actually a chlorofluorocarbon that was actually banned since the 80s from being manufactured. But again, healthcare is exempt from that. So that PRN Ventolin that we often prescribe as well, that propellant, it actually is a chlorofluorocarbon that has a significant contribution cumulatively to the ozone layer. So when there's an appropriate clinical situation to perhaps switch to a dry powder formulation instead, of course, recognizing that there are still situations where we still have to use our meter dose inhalers in preschool children, acute emergencies. A patient have to have the appropriate be able to do the maneuvers for certain devices, have the sufficient inspiratory force for dry powder formulations. But there's also ongoing research to see if we can come up with other propellant. So these are the questions that we're asking as clinicians, as researchers, as educators, as ways that we can actually take this whole concept of climate change and how we could bring it into the patient interaction in a practical way. So what we've done in the world of rheumatology is that in 2023, the Ontario Rheumatology Association, we created our own little volunteer task force, and then we came up with this toolkit. And this toolkit, I'm happy to circulate the link later as well, but what it is that it's meant to be an easy to read. So it's not very heavy reading. You could probably read the whole thing within 5 minutes. And it is meant to be an easy guide, not just for clinicians, but even our staff, our non-medical staff, whether it's our administrators, our nursing staff, or other colleagues as well, is really to be able to implement sustainable solutions within the delivery of our healthcare services in the ambulatory care world. There's also toolkits already available. If you just look up Peach Ontario and you go into handbooks, there's actually a handbook for hospitals as well as for long-term cares that already pre-existed. So then we're currently with Dr. Hazel as well as Dr. Bernatsky, we're in the process of updating it because so much has changed in the past year, particularly the rapid pace of research, to have an update for 2024 as well. So this is just to give you some highlights of what this handbook covers. So I'm just going to break it down on clinical, medical education, as well as patient domains as well. So I get it. So as a clinician, I realize we have so much to learn, so much to update all the time. And the last thing we sometimes feel is that we have yet another topic we have to learn or take on as well. So sometimes clinicians ask me, what's one thing I need to know of all this? And the only thing that any of us need to consider doing is deprescribe. Because what happens, each of the medications, each of the tests that we order that may not be needed, that all contributes to what I call the little footsteps that make up the global carbon footprint within healthcare as well. But again, you don't necessarily even need to apply an environmental lens to it, just purely from a patient care perspective, streamlining medications, streamlining investigations. Not only does it reduce the time as well as the systems costs, both for the patient as well as the system as well, it also streamlines patient care. So ultimately, if you just think of choosing wisely principles and just about providing the best care for the patients in a streamlined way, you are already doing environmental work, even if you might not see it from that perspective as well. So the good news is that you don't have to learn something extra in order to participate in these efforts. And then as the data continues to evolve, is really thinking about medication equivalent options as well. But again, that is still an evolving area as well. Just as a concrete example, again, it's not going to be the biggest game changer, but it's often very popular, is like the idea of the examination paper rolls. So we have them in all of our offices, or many of our offices. It rips easily. It doesn't even cover the full table as well. But what ends up happening, we also know from the pandemic, if we really need to sanitize a surface, we really ultimately need to wipe it down. So there's certain things that we've just traditionally always done in healthcare, and is really using this opportunity to reevaluate whether we really need to do it, or what my ID colleagues call hygiene theater versus truly sanitizing a surface. In many hospitals, but sometimes in clinics as well, sometimes moving towards more reusable gowns and linens. Of course, when it comes to the clinical world, if you're outside of a university setting, sometimes you don't quite have the economies of scale. So that's why different solutions, these are just meant to be ideas. You really ultimately have to tailor whether it's appropriate in your clinical context, and whether ultimately, honestly, if it's worth your effort, or if it's something you can ultimately delegate to something else, to someone else. The idea of also PPE, so we also went through the same pandemic in terms of not enough PPE, lots of PPE to somewhere in between probably now. And the idea that more of the merch docs are running a campaign in terms of gloves off, whether hand hygiene sometimes works better than single-use gloves, for instance. And even other things that we don't necessarily think about. And again, it doesn't have to be us, but also just the way we just, the culture that we work in, is the idea that, for instance, with transfer of medications, so if a patient is transferred from, let's say they're admitted, they go from admission to a rehab facility, some institutions actually throw all their medications, so all the inhalers, everything else, and they just restart from scratch. But the idea that if the patient is using the same medication, it's the same person, just to transport their medications. So just little changes that way is really the idea of really reducing unnecessary waste without impacting patient care from that perspective as well. Other things hospitals are doing is the idea of reusable sharps, because anything that is considered biohazardous is automatically incinerated, which generates more emissions compared to, I would say, regular waste that goes towards the landfill. So in some hospitals, they have the hard plastic, it's wall mounted, and there are some programs where they actually dump the contents, incinerate that, but then they sanitize and reuse the container as opposed to just throwing entire things out, for instance. There's also what I call high yield recycling. So high yield recycling would be things such as PVC plastics, most common use plastic in healthcare. So that includes a lot of our IV tubing, as well as suction tubing, as well as IV bags, as well as oxygen masks, for instance. And what ends up happening is that this was actually a campaign coming from our nursing colleagues. And then to recognize that after we run infusions, do day medicine unit things, is that all that stuff was just being thrown out as well. But to realize, again, plastics cannot be recycled indefinitely, but if we can get another 1 or 2 uses out of it, PVC recycling is something that can be done at the hospital level. And hospitals like it because you also help reduce costs instead of automatically sending everything for incineration. That's the idea about sorting the waste. And then there's other like just FYI things in terms of like LED lighting, more energy, lower costs, thermostats. The idea of turning off our devices end of the day can also be helpful. And again, these are just different ideas. Some of it might speak to you, some of it might not at all. So this is just meant to inspire ideas. When it comes to the education realm of things, so previous environmental messaging was, well, you can recycle, please recycle. However, the unfortunate reality is that only about 20% of paper as well as 9% of plastics is truly recycled in Canada. This is a combination of due to cross-contamination. If it's contaminated, it gets and ends up in the landfills, or also depending on what different municipalities are able to manage. So even within a 20-minute radius, you can get different levels of recycling of what their conveyor belts or machines are able to process. So you get huge variations even on a systems level. So I see Dr. Mandel is on this call as well. So she is our Canadian Rheumatology Choosing Wisely, our lead on this topic. So she jumped into the role, and over a course of a very small amount of time, we came up with 2 statements, because Choosing Wisely also realized that they were also part of this environmental initiative. And they asked all the national societies to actually come up with 1 or 2 statements to bring a lens to reducing our carbon footprint within healthcare. And our 2 statements were not to perform repeat testing without considering past available results. But again, being practical clinicians, we also had a huge caveat explaining that tests should be readily available for the ordering provider so that we're not having administrative burden trying to look for these tests, because often practically it would be easier to reorder from that perspective. And then the idea of separating regular waste versus biohazardous waste, because different individual practices or different institutions have very different policies on how things are sorted from a procedure level. And if you're not hearing about it through this, you might also be hearing it through either undergrad, postgraduate medical education, or at the Royal College level as well. When it comes to patient perspective as things, so things such as virtual care, for instance, so I know different physicians have different opinions on virtual care, whether we're referring to video or phone, but for a stable follow-up patient that lives very far away, and the difference is no care versus virtual care, sometimes it's an option, and again, depending on the provinces, if it's compensated for as well. So with all that caveats, there is data to say that it does result in cost, travel, and time savings. But of course, willing to acknowledge there's definitely still an importance of the physical examination. And it is only in limited situations where it might be appropriate too, but something of consideration. So even, for instance, at my institution, we actually have a virtual medicine clinic as well as an option if someone is unable to get to clinic. So other things we can do as physicians too, as Dr. Bernatsky mentioned, unfortunately, there is a link between lower socioeconomic status and also the ability to access nature too. So Parks RX, PARX, is actually something that was started in BC, but is actually Canada-wide now. So as a physician, we can get an empty template. And what it is that basically it just pre-populates our name as well as our license number. And you can actually prescribe things like a free Parks Canada pass, or even various like zoo, museum, or other initiatives as well. A patient just has to show up at the entry with that little piece of paper and their ID, and they're good to go. Just again, not game changing, and it's not going to address all of someone's determinants of health, but these are some initiatives that are being done that is meant to be easy to do for the physician. Of course, other things such as exercise prescribing, even if we mention it, let alone if we put it on paper, sometimes that can inspire patients to participate in exercise, which is very helpful in the vast majority of illnesses we treat. And then at the hospital level, tons of food waste going on. So some hospitals are also looking into having more plant-rich options, but also even ordering on demand. And again, this is not even related to clinical care that we do as well, but these are things that are being done at the hospital level. So there's something called the hospital scorecard. So if you look up hospital scorecard, they actually looked at a few different institutions across Canada as well. And what they looked at was how hospitals can actually participate in this, because the vast majority of admissions are still coming from hospitals as opposed to non-hospital based clinics. And these are the big domains that that are emissions intensive. That's energy, waste, water management. So things not within our domain, but again, just recognizing the global context of high yield items, which is why a lot of hospital as well as institution sustainability task force are usually not physician based. Usually they're actually involving people in these departments as well, and they actually have the bigger impact. So again, as physicians, sometimes we can raise awareness and bring up the question without having to actually do the work involved. Our surgical as well as our anesthesia colleagues are focused on the ORs, is another source of big emission within hospitals. And then other things such as food, procurement contracts. So ultimately, as a physician, I just want to be able to do the procedure I need to do, see the patient I need to see. So this is where hospital procurement managers can play a big role in greening the supply chain. And I mentioned briefly virtual care, if appropriate, depending on provincial guidelines on this and also compensation. And ultimately, it's about climate resiliency. What is the ability of our institutions to respond to a major event or adapt to a major event? And these things are already happening. So that can range from damage to infrastructure to also even the ability for staff to get to their work. So during my training days in Calgary, we were flooded out and most of the residents and staff couldn't get to the site they were working at, which required a lot of improvisation when it came to coverage. So these are the questions that are being asked because depending on the local context, certain things may be realistic. And as Dr. Bernatsky mentioned, I'm sure none of the docs or healthcare staff or patients anticipate in Yellowknife that they were all going to be evacuated last summer. So what are the benefits for the provider, for the healthcare worker in terms of all this? So first of all, this generates ideas from the team. So again, this is not meant to be only physicians to do. If anything, we can lend our voice to raise the issue, but really encourage others to take this on from a practical standpoint. But we could also help streamline the use of resources, medical and non-medical side, incorporate patient assessment risks, as Dr. Bernatsky mentioned, in terms of managing chronic longitudinal diseases. What is people's plan? For example, if they are in a wildfire zone, how are they going to manage their medications? Do they pack enough supplies? So forth as well. We can contribute in our own small way in terms of reducing the healthcare carbon footprint. And there is the American Medical Association guide where they estimate you can save about $2,000 per year per MD in an ambulatory care setting as well. And the idea when I talk to trainees is really about risk-proofing your insurance. For instance, in Ontario, you can actually build buildings in a flood zone as well. So really the idea that you want to risk-proof your practice, because if we're not able to work, we're not able to provide care. And for some of us, that also has an income impact as well, ultimately. So in summary, climate change and its impact on health is happening in our current lifetimes. It's no longer think about your children or grandchildren. It's happening to us now in the present, in the coming years. These changes do affect people more vulnerable, who are already vulnerable earlier and more severely, and affects their ability to also recover from these events as well. And that we ultimately, as physicians, have a direct and indirect role to play as healthcare providers. And ultimately, I believe our healthcare system can embark on more environmentally sustainable approaches, streamline patient care, while saving costs, which is something all the hospitals and governments love hearing. So with that in mind, I just wanted to give plenty of time for questions, and I'll take a look at the chat because it's been quite active. Thank you.
Thank you. Thank you so much, Dr. Stephanie Tom and Dr. Sasha Bernatsky. Really interesting, actually, terrific presentation. Definitely a lot to learn and clearly a lot of work to do. There are lots of comments in the chat. I see people have gotten involved in the conversation here. Kaberi, are you able to unmute yourself?
Yeah, for sure. I think we need a Stephanie Tom here, Sasha. This was really, I mean, I love.
I nominate Sasha and Beth. They're on the task force.
No, Ariel.
I mean, I love how you've taken an important global issue and reminded us all how important it is to our daily practice and how we manage healthcare and how we treat patients. And I think all too often we ignore the impacts of climate change, war, indigenous health issues, and so thank you for doing that. And one of the chat items that was coming up here was that, I mean, I remember early in the pandemic on the 15th floor CTU, I was really happy to see this influx of reusable gowns. And that's what we were using for quite a while. And then suddenly changed back to those blue gowns. And we just, every time I see, you know, those garbage pails overflowing with blue gowns, you know, I have this sinking feeling. So I don't know who makes those decisions. But that was one issue. And then the other thing I've noticed is our trainees, especially the ones who were trained around the time of the pandemic or started their training, every patient I go in to see them with, they automatically put the gloves on. And I say, well, you know, we can wash our hands before and after, but they're really kind of, I guess because of the pandemic and maybe some of the rules around it at that time, but these are people who are not even necessarily, you know, under precautions that they're using it. So I'd love to hear your comments on what's happening in Ontario, Stephanie, and what you think, Sasha, about those kinds of initiatives.
Yeah, so I agree. Like I've noticed very similar things. I would say some institutions have reverted back to like PPE is plentiful. It doesn't matter, but it's nothing like stress or cost that always forces us to be creative and adapt from that perspective as well. I would say it depends on the institution as well. Usually the most common thing that comes up is IPAC. They always say, well, what does IPAC say? So if you just talk to your ID colleagues, or if there's ID colleagues here as well, they're usually, when I ask them, I'm like, can we do this? They're like, yeah, that makes sense. So as long as the hospitals are usually looking for their blessing in order to do anything or not do anything from that perspective as well. And most institutions have a sustainability committee now because they're looking at cost savings. There is the environmental lens, but they're also looking at cost savings. So I would bring it up and ask around and see. I would maybe talk to the IPAC people first and see who would actually be in charge of that. And ultimately, it probably is a non-physician down the line, if I had to guess. Usually it's either like a procurement management or someone down the line who made that business decision. So it's really, again, to be efficient in terms of our bringing up the question, I would talk to maybe an IPAC colleague first, and then talk to whoever you would think within leadership would be the procurement person. That's what I would say as well. If it helps you answer a bit more concretely to if you look up Peach Ontario under the guidebooks, they actually have an advocacy 2-pager of who you should ask within hospital institutions who would likely be responsible for stuff. They have a 2-page advocacy roadmap as well, if that helps. But in terms of practices, yeah, for sure. Sometimes I find I'm guilty of that too. I'm going to these presentations where I just automatically want to gown up or glove up as well. And it's because it's been ingrained to us since the pandemic. So really having to be strategic of how we go about these changes as well. I think it's really nudging our culture of how to preserve patient care, but also being appropriately risk assessing like we would always do, if that helps answer your question.
Very helpful. Sasha?
Yeah, so a couple of things. It's absolutely the people who are responsible for buying that I think have the most impact, and their job is to, they don't have a certain amount of money to work with, but there is. So I think Sylvia put a link to MUHC sustainability.
Sustainability Development Committee. Thank you,
yeah.
Sylvia.
Mm-hmm. So that's great.
The link is there. Yeah, for those who want to see the link. I was going to ask Ingrid, would you like to join the conversation? Ingrid, are you there?
Yes, hello. I was just sort of wondering, I mean, Sasha describes what this gold certification means during the construction process, but what does it actually, does it also apply to the ongoing functioning of the hospital?
So I put a link, I thought that was an excellent question, and I put a link to a web page there that I'm going to show for everybody. So I thought it's interesting because it sounds so good, and then I'm like, oh, but it's kind of like how things were built, a lot of how things were built, which is, again, we shouldn't downplay it, right? I mean, just because somebody does something that's good for planetary health because it costs less, it doesn't negate the fact that it is good for planetary health. So it's good that they did this during construction, and things that you do, it's because it's a new facility, right? So they have stuff like low flow faucets that are and the reduced light, like they can, because it's a new facility, they can implement, they've purchased and installed new things like these low flow faucets, and it would, maybe not make sense to do that at Montreal General Hospital because it would actually be a great expense, and maybe, when you take something that's existing and then just replace it with something new, this doesn't mean that it's going to have the same impact on the environment as choosing something that's environmentally friendly when you're building something. So I guess that might make a little bit of sense. And then there are things like charging stations for electric vehicles and trying to make the MUHC better for people who cycle to work. I don't know. I feel like people who cycle to work will cycle to work no matter what. So I'm not sure if that has a huge impact, but I think recycling is really important, and I don't know how well we recycle at the MUHC. It does seem like it'd be really interesting to find out how much of the tubing from IVs, for example, can be recycled. I think that was a really good point. So I put the link into the this website here if people want to follow it. I want to say something as a follow-up to Kaveri's comments on the gowns. And again, I put a link, and I hope it's not I hope it's fair to draw attention to this. And that is, so I'm going to share my screen again. We actually have a medicine trainee, Owen Liu, who gave a presentation for a rheumatology group last week, who's done a lot of raising awareness as a medical student, as an innovator to try to mitigate the health impacts of climate change in Canadians. So I don't think Owen is on the line right now, but I asked Owen, how come we still have disposable gowns on the medicine floors? And he said, I asked, I'm sorry to say this because there's a reason for people doing it, and there's nobody who can defend themselves here, but he said, I asked, and they said it costs too much to wash gowns. And so, I have to follow up with Owen about this and find out who he talked to, but it was, I think, when all of you heard that, didn't your heart just drop? That this was a decision, and like maybe it was the only decision that could be made, but to think that a decision was made not to use reusable. Go ahead.
Well, I just think that cost is an issue for so many of these decisions. I think as physicians, we have impact, well, in three ways. First of all, what you do yourself at home or in your personal life. You have the impact in your professional life in terms of your work environment, which we've been discussing, use of paper, gowns, lighting. And then the third way you have an impact is, how you can influence your patient's, behavior. But some of the things, like the Parks Canada Pass, which is free, that's a good thing to know. But a lot of the other things that you might want to encourage patients to do are actually costly for the individual, So I think, cost in the short term is always going to be a challenge compared to what people, the problem is that people perceive these climate and pollution issues as long-term problems. There's no sense of acute urgency. And so then because of that perception, I think cost becomes more of an important, factor in the decision-making.
I'd like to invite Linda. Are you able to join the conversation because you've made a few good comments there? Linda Fiera?
Yeah, hi Nadia. Thanks for asking me, and thanks for the fantastic talk. I've been involved in this process for quite a long time as a sustainability lead in respirology, and I'm also on the Planetary Health Committee at the Royal College level as the McGill representative, and also did a course on climate change and then PGME level. This is it's really hard. It's like a hydra. You try to get rid of some exam room paper, for instance, and then suddenly the prepose or the cleaning guy puts the paper back. And so it's like a real systems problem. And in fact, I had to go around and remove all the rods on the back of the table so that no paper could be replaced again. But it really is a commitment on an individual level sometimes. And there's a great deal sometimes of frustration in terms of trying to mitigate some of these things, which are really low-hanging fruit. Some of the things that we end up doing, like trying to get bonnets off of patients in the bronch suite. I'm currently working with a committee to try to have a position statement on bronchoscopy, making sure that we're not using reusable bronchoscopes and making sure that all of these things are in place. And that's going to be at the CTS, the Canadian Thoracic Society level. So It's great, all this work that people are doing, but we also are working somewhat in silos, and it's important that we all kind of band together. There's a number of useful things like cascades, which I'm sure you guys are aware of, that are doing a lot of the puffer work and all the other work in other surgical units and anesthesia and things like that. I think all of us working together is how we're going to move the dial. Thanks.
Linda, can you repeat it? So you are doing this for the Division of Rest. Your title, what is your title in the Division
Yeah,
of
so it's
Rest?
kind of a self-imposed title in a sense. I'm the sustainability lead, but what I did was I did do some of the courses in the McGill Sustainability Office, and allowed us to achieve a bronze certification at the McGill Sustainability Office. And it really means that you've made a commitment to making change within your work group. And that can be whether you work in library science, whether you work in medicine, and we were the first medicine group that achieved a bronze level certification from the Sustainability Office, and then from there, went on to become a scholar for the sustainability teaching group and creating a course, and then got involved in the Royal College level. So again, these are things that hopefully we're going to pass on to trainees as well. As a program director, I'm always kind of in making sure that my trainees are aware of climate impacts and making sure that that's part of the curriculum as well. And just again, having all of these things like as what's put up here, cascades and CAPE and all of these things, that it's on everyone's radar so that they can get involved, whether it's on a small level, a national level, whether it's on a institutional level. All these things are super important.
Terrific. I'm not aware of any other division in the Department of Medicine where we have a sustainability person like yourself. So I'm very impressed. Thanks for sharing that with us. Ingrid is asking if you can provide the link to your course in sustainability. I think that would be very helpful. And
yeah, sure.
it would be, I'll speak to Mark about that, but it'd be interesting to see other divisions participate in that. And congratulations on getting your certification for the Division of Respirology. That's really great news.
Thank you.
I see. And Ning Z, do you want to make a comment?
Sure. This is just putting a plug for Owen and Rosemary, who are internal medicine residents, and actually working hard in putting together a curriculum needs assessment survey that's going to go out nationwide to all the internal medicine programs, as well as family medicine hospitalist track, to really target people who are going to make a difference, who are going to be working in the hospital, and who are going to hopefully make a difference in the future. And inside that needs assessment, actually put in a knowledge test with answers and explanation that has educational value to it. So we're very excited about this project. So it's just putting a plug for them for the excellent work they've been doing.
Fantastic. Thank you. We're coming up on the hour, so we will have to close the grand round. First of all, thank you so much, both Dr. Bernatsky and Dr. Tom, for bringing this topic, really bringing this topic home, because it's not something we think of. We think about a lot of things as healthcare, people working in the healthcare environment, but this is not something that we're thinking about every day, most of us anyways. So I really appreciate you taking this home and giving a lot of food for thought. Really terrific presentation. And I'd like to thank also everyone who participated and joined this panel at the end, this impromptu panel. Thank you very much for participating in that. So clearly a lot of work to be done. Please do share the link, Linda, and let's get more people on board. Greatly appreciate these rounds. Thank you so much, everyone. I wish you a great afternoon.